Ramakrishna Hospital and also from outside, from the city of Coimbatore, and all the doctors and postgraduate students from various institutions. This is one of the webinars, series of webinars we are conducting for the last 3 years. Every, third Saturday. And on behalf of management of Sri Ramakrishna Hospital, myself, I am Dr. Sumaran. I am the Dean and Director of Sri Ramakrishna Hospital. Welcome all of you to this webinar. And we thank all of you for joining. And today's speakers are Dr. Ganesh Prasad, our senior urologist, who is going to talk about prostatism, myths and facts. And the second speaker of today is Dr. Madhushankar, a senior nephrologist. He is going to talk about the decoding urine analysis. Seems to be a novel topic, and so both the speakers have willingly accepted our invitation to talk in this webinar, sparing their valuable time. I should thank, on behalf of management, Dr. Ganesh Prasad and Dr. Madhushankar. I request Dr. Ganesh Prasad to start with the proceedings, with this lecture. Thank you.
Good evening, sir. Thank you for the introduction. Welcome all the consultants to this webinar. And good evening to all the consultants who are online and who are viewing this webinar, live webinar. So without wasting much of time, let us straight away go into today's topic. Hope my slide is visible, Mr. Murali.
Yes, sir.
Yeah, okay. So today we are going to see about prostatism. The word is different. It's not it's not regarding to prostatic enlargement. The word is prostatism. What are the myths and what are the facts about prostatism?
Sir, so can you please make this presentation to full screen, sir?
It is
full screen mode, sir.
Yeah, it is shown in full screen here in my screen. Okay, we'll try again. Is it visible in full screen now?
Yes, sir.
Yeah, okay, right. So let's move on to the word prostatism. The prostatism is actually a syndrome which is associated with bladder outlet obstruction. And the commonest cause for prostatism is benign prostatic hypertrophy. The word doesn't essentially mean benign prostatic hyperplasia. It is a term which is used to denote rainbow symptoms, which are 7 symptoms are there, which are located and which may be caused by benign prostatic hyperplasia or not. So is prostatism the same as BPH? It's not same as BPH. The symptoms which I mentioned here, like dribbling at the end of urination, a weak or interrupted stream, trouble in starting the urine stream, urinary urgency, frequency, nocturia. So all these are symptoms which may be present in prostatic enlargement or in other scenarios. But many a times what happens is when a general practitioner sees a patient, an elderly male with all these symptoms, he presumes all these symptoms are because of prostatic enlargement, straight away starts the patient with tamsulosin, and he sees how the effects are. Many a times these people respond very well to the alpha blockers, that is tamsulosin. They actually come out with very good results. Sometimes they don't respond to alpha blockers. So the motive of today's speech is to say what are all the scenarios in which you need some extra help, or what are all the conditions where the diagnosis is slightly different or it's a googly ball. So let's go to the basics of benign prostatic hyperplasia. We'll see certain things about benign prostatic hyperplasia. So enlarged prostate is a consequence of age. It's not a disease, it's just a consequence of age. 90% of men over 80 years have prostatic enlargement. In 50 to 60 years age group, about 50% have enlargement of prostate. So every year, every decade has a 6 ml increase in the size of the prostate. So that is regarding the basic anatomy of prostate. You have the bladder there, and near the bladder neck, you have the prostate. There are three main zones. You have the transitional zone, the central zone, and the peripheral zone. The transitional zone is the one which is located around the urethra. The benign prostatic enlargement initially starts in the transitional zone and slowly it engulfs the urethra. Then you have the central zone. The changes can happen there too. The peripheral zone is very peculiar. The one you see outside is the peripheral zone that is prone to develop prostate cancer. So cancer is very common in the peripheral zone, whereas benign prostatic hyperplasia is very common in the transitional zone and central zone. So anatomically, the location of the pathologies is different. So as the prostatic capsule also plays an important role. It plays a donut effect. So as the gland enlarges, the prostate capsule compresses the gland further, and that compresses the urethra, so produces something called a donut effect. Dog is the only other species known to develop benign prostatic hyperplasia, and it rarely develops prostatism symptoms. That is the basics about the receptors. The bladder neck has alpha receptors, and that is the reason why most of the general practitioners prescribe alpha blockers in the form of tamsulosin. The bladder musculature, the detrusor muscle, has two types of receptors, beta 3 and M3 muscarinic receptors, the use of which I am going to tell you later. Then there is a specific enzyme called 5-alpha reductase. There are two types, type 1 and type 2. Type 1 is present in skin and liver. That is responsible for hair loss, and many of dermatologists will be prescribing 5-alpha reductase type 1 for hair loss. Type 2 is located in prostate that converts the testosterone into dihydrotestosterone. And this dihydrotestosterone is responsible for further prostatic growth. So if you knock off this enzyme by means of giving a 5-alpha reductase inhibitor, then the size of the gland, the growth of the gland will get hampered. The pathophysiology of bladder outlet obstruction, it is not very simple. There is a mechanical component, a dynamic component, and a detrusor component. So the drug options which are commonly used in day-to-day practices, we have alpha blockers, which may relax the bladder neck. We have 5-alpha reductase inhibitors. As I told now, they reduce the size of the gland. Then we have beta 3 agonist, anticholinergics, phosphodiesterase inhibitors. All these are group of medications which are commonly used. There are various options in alpha adrenergic agonists, starting from tamsulosin, terazosin, doxazosin. All these are various options. 5-alpha reductase, we have finasteride and dutasteride. The third one is antimuscarinics for overactive symptoms like frequency, urgency, nocturia. You can easily remember as FUN, F-U-N, but it's not fun. Frequency, urgency, and nocturia are overactive symptoms which are managed by anticholinergics. Example is tolterodine. Older anticholinergic was oxybutynin, but it has a lot of side effects, so we have shifted over to tolterodine. Once again, this shows which particular drug will be acting on which receptor. Tamsulosin basically acts on alpha-1 receptor in the bladder neck. There was an older drug called as prazosin. This acts on all alpha receptors. The alpha receptors which are present in the vasculature are also blocked. So the patient will have severe hypotension. Whereas alpha-1 receptor specific tamsulosin acts in the bladder neck. There are super specific receptor blockers like silodosin. Silodosin acts specifically in alpha-1A receptors. And there are alpha-1B and D receptors. Naftopidil acts on alpha-1D receptors. This is just an overview about what are all the medications which are given. Added to that, silodosin also prevents the action which happens through the C fibers, the afferent action, and prevents overactivity which happens in the bladder. Now let's move on to the myths and facts. This is a myth 1. All patients with obstructive voiding symptoms more than 50 years of age have prostatomegaly. It's like saying all that glitters is not gold. So I'll tell two examples here. This is the case googly one. The 55-year-old male came with symptoms of straining to void, decreased urine stream, But a characteristic history finding here is the patient had burning sensation while voiding. Every time he voids, there is a burning sensation. Patient never responded to tamsulosin. Urimax was the drug which was prescribed outside. Patient never responded. He changed the drug to other company, Tamlin, Tamlosin, Tamlocept. So he gave it different companies, but still there was no response to tamsulosin. Then he started silodosin, no response to silodosin. Actually, the symptoms got worsened on taking tamsulosin and silodosin, and he was referred. The investigation showed that the blood investigations were normal. The serum creatinine, the renal function tests were normal. The urine routine was absolutely normal. Ultrasound showed both the kidneys were normal in size. There was a small clue. The bladder wall was thickened. There was a slight thickening in the bladder wall. The prostate was absolutely normal. And there was one more clue. There was high post-void residual urine. That is, after passing the urine, we have to do a scan for all people with prostatic symptoms. Prostatism or prostatic symptoms, I request all the practitioners to do a post-void residual urine. Many a times you forget to write that in the ultrasonogram form. Look for post-void residual urine. That will give you a superb clue. Here, that is the only clue. You can find that after passing urine, there is 130 ml of urine held inside. So what next? Many a times we are stuck in such cases. So what to do next? We have to do one more investigation called uroflowmetry. So uroflowmetry is a simple office-based investigation, a very, very simple investigation where the patient is asked to pass urine inside a Western toilet, which is attached with a sensor at the beneath. The sensor at the bottom. This sensor will sense the speed of the urine and it will give a pictographic representation by giving a printout from a computer printer which is nearby. So based on the curvature, we will have an objective view of what is happening with the urination. The actual curve of a human being, a normal adult human being, is that of a bell-shaped curve, a normal Gaussian bell-shaped curve. It starts very slowly, the urination. It reaches a peak and then it comes down slowly. If it is in an interrupted sine wave-like pattern, and if the peak reached is less, then that means that there is an obstruction, more likely to have prostatic enlargement. If the curve is a uniform Plato-shaped curve or a very flat curve, then that means that there is some blockage in the passage of urine through the urethra. There is no problem with the bladder neck, but there is a problem with the urethra. And that signifies there is a stricture in the urethra. That is what happened in this particular patient. He had a Plato-shaped curve, following which this patient underwent an X-ray investigation, a simple X-ray investigation called as ascending ureterogram, where we give the contrast back through the urethra. And here you can see that there is a narrowing at the level of bulbar urethra. So this narrowing at the bulbar urethra or stricture urethra was giving a symptom which was very similar to prostatic enlargement. He underwent buccal mucosal graft urethroplasty and he is fine. So this is one differential diagnosis. Many a times this is missed. The clue here is, one, the patient will have burning sensation while passing urine. Number two, actually alpha blockers will aggravate the problem. Once the patient is started on alpha blockers, because you can see the urine will come all the way from the bladder neck to the stricture region very easily. And from there, it can't come outside. So actually the symptoms are more by using alpha blockers in case of stricture urethra. So you should have in your mind, if the patient is not responding well, then this can be one diagnosis. This is the other googly ball. The second common thing which is missed. Yes, you can see there is a case of a 60-year-old male who is a diabetic for a very long duration, 20 years diabetic, who is passing a thin stream of urine, who is straining every time he is passing, feeling a incomplete emptying sensation is there. The general practitioner started tamsulosin. There is no response to the treatment. Blood investigations normal, but for slightly elevated creatinine values. His sugar values were high in urine. There was some proteinuria. There are granular casts seen in the urine. There was some bacteria which was also culture positive. So after treating the infection adequately, an ultrasound was done. In ultrasound, you can see the corticomedullary differentiation is altered with increased cortical echoes. That means the diabetic nephropathy has slightly set in. There are no hydroureteronephrosis. The bladder wall is mildly thickened, but the prostate is normal. In spite of all voiding symptoms and voiding problems, the prostate is normal. So if there are prostatism symptoms and the ultrasound says the prostate is normal, you should always think these two diagnoses in the back of your mind. You can see there is one more important clue, the post-void residual urine. 200 ml of urine is staying inside in spite of him passing urine. So that is the reason I am insisting again, you should always ask for post-void residual urine while you do a ultrasonogram of abdomen. There are 3 clinical clues in this case, which I didn't reveal initially. On careful questioning, the patient said that he is having constipation, like any other diabetic patient who is having 20-25 years of diabetes. So constipation was there. A rectal examination proved that the sphincter tone is completely gone and the patient had a lax anal tone. The anal tone was very lax. The patient also had clinical features of diabetic neuropathy. So the diagnosis was much more easy. But still, we performed one investigation to prove that that's called a urodynamic study. In the previous thing, we saw what was a uroflowmetry. Here it is a urodynamic study. This is an instrument which will test the pressure inside the urinary bladder and find whether the urinary bladder is having a capacity to pump the urine out or not. So this urodynamic study gave a very clear picture that the urinary bladder is not able to contract and pump the urine and push the urine outside. The same thing is happening with the bowel. There is atonia of the bowel and the patient is having constipation because of that, all because of diabetic neuropathy. So the simple diagnosis is the neurogenic atonic bladder. So these patients don't respond very well to the alpha blockers, but they do dramatically well. 50 to 70% of people respond well to bethanacol. This bethanacol is a cholinergic drug which increases the contractility of the bladder and helps in pushing the urine outside. Many a times, even the constipation also gets cleared and gets corrected with bethanacol. So this is one more scenario where you have to think in case of obstructive voiding symptoms. Now, the other myth is the bigger the prostate, worse the symptoms are. Is it true? No. The bigger the prostate, worse the symptoms are. The statement is not true. Even in your practice, you would have seen patients coming with only 35 grams, 40 grams prostate with a lot of symptoms. Patient will be complaining, I'm not able to pass, I'm passing urine only in dribbles. Whereas people who are having 100 grams prostate or 120 grams prostate, they will be wandering without any symptoms. They'll be absolutely okay. They'll be voiding normally. Sometimes they may say that only the ultrasound is telling that I'm having prostatomegaly, but I'm perfectly okay. Can this happen? Yeah, this can absolutely happen. How can this happen? So this is a pictographic representation. This patient had only 30 grams prostate, but the entire prostatic enlargement is happening at the region of bladder neck. And this lobe is called the median lobe. The median lobe. And this lobe, which is located near the bladder neck, if it is only going to get enlarged and if it is going to block the bladder neck completely, then even though ultrasound will say it's only 30 grams prostate enlargement, still the patient will have miserable symptoms. Patient will have severe obstructive symptoms. Okay. So this is one more picture, an ultrasonic picture showing that the median lobe getting enlarged and occluding the bladder neck and producing very severe symptoms. So the size doesn't matter. Size is immaterial. Immaterial of the size, still a very small prostate can produce symptoms. One more picture which shows that the enlarged bladder neck. You can see the median lobe projecting into the bladder neck. We use a term called as intravesicular projection of bladder neck or intravesicular projection of prostate. If the projection is extending for more than 2 centimeters into the bladder neck, then the medical management won't help in these people. We have to do surgical excision of the prostatic gland. This is just a cystoscopic picture. There you see the bladder with a lot of trabeculations. It is chronically obstructed, so there are a lot of trabeculations, and this is the enlarged median lobe. You can see it like a goalie soda blocking the flow of soda out. Okay, so you can see it is propouting into the bladder neck completely and blocking the opening completely. Yes, now let's move on to the next myth. BPH is linked to the prostate cancer. So whoever is going to have BPH, there is a chance of having prostate cancer. No, that is not a fact. So as I told previously, prostatic enlargement happens from a different area called transitional zone and central zone, whereas prostatic cancer usually happens from the peripheral zone. So both are in different locations. The only common thing between these two things is both happen during aging. So after 60 years, both can happen. So age is the only common factor. Apart from that, there is no correlating factors. What we are supposed to do, and what I request all the general practitioners or practitioners of other specialties, whenever you see a prostatic enlargement, don't forget to do prostate specific antigen in these elderly gentlemen. As you know, prostatic cancer is one among the top 3 cancers. So it's always good to get the PSA done in these people to catch the malignancy at the earliest. So if the prostate specific antigen is more than 4 nanogram per ml, we should be a little cautious. If it is more than 10 nanogram per ml, then we should be highly suspicious that it can be cancer. The BPH only occurs in older men. That is the other myth. It can also happen in people who are there in their 40s. We have seen a lot of people at their 40s presenting with prostatic enlargement. People who are genetically prone for prostatomegaly sometimes present at a very younger age and sometimes may present with very huge prostates. Sometimes there is an entity called as bladder neck elevation. That is the median lobe of the prostate, which is located there, may isolately get elevated, and that is called bladder neck elevation. So, and these people are usually very young people and they have obstructive symptoms. When we do an ultrasound, the ultrasound will come as normal, but in spite of that, their urine flow will be very, very poor. So this is the picture actually how the bladder neck elevation looks like. So there you see the bladder, prostate and kidneys. So we are moving on to the bladder neck. Just to show pictographically how the bladder neck looks like. That is the entrance of the bladder. So we call it as bladder neck. You're entering into the bladder now. There is a verumontanum, and where there you see the bladder neck. So that bladder neck which is elevated there will act as a dam, and it will prevent the flow of urine. So when we excise the bladder neck, that's what being done here. Putting a small incision at 5 o'clock and 7 o'clock position, we excise the bladder neck and break the bladder neck so that the flow is absolutely okay. So these problems can happen in very young chaps, and we should not come to a conclusion that prostate problems can never happen in young chaps. One more entity which happens in young people who are immunocompromised, or young people who are diabetic, or young people who are sexually hyperactive is acute prostatitis. Acute prostatitis can very well happen in any of these people. The prostatic inflammation is sometimes very severe that it can progress to prostatic abscess also, and we have drained lot of such abscesses. Sometimes the bacteria stays very safely inside. It can stay inside the prostate for months together and keep irritating the patient continuously, producing prostatic enlargement like symptoms. If you do ultrasound, everything will come as normal, but the patient will still have symptoms, and that is called as chronic prostatitis, chronic inflammation of the prostate. It may be a bacterial prostatitis or a chemical prostatitis, but that can happen in young people. One more diagnosis which you should have in your mind. Myth 5, having surgery for prostatic enlargement might have added benefits for preventing prostate cancer. As I told previously, both arise from different zones. Prostatic enlargement from the transitional zone, and prostatic malignancy from peripheral zone. So this is the picture what happens after removing prostatic chips in transurethral resection of prostate. So during transurethral resection of prostate or prostatic surgery, this is what happens. We remove the median lobe and we remove 2 lateral lobes, but the peripheral zone is not approached, it is kept intact, because removing the peripheral lobe will lead to torrential bleed and the patient may sometimes lose his life. So the peripheral zone near the capsule is kept intact. The malignancy may arise from this peripheral zone at a later day. So the patient cannot be very free thinking that doing a TURP or transurethral resection of prostate saves him from prostatic cancer. Absolutely not. So removing prostate or doing TURP doesn't make someone immune to prostatic cancer. Still, prostatic cancer can develop from the peripheral zone. That is showing the cut section of prostate. You can see in the peripheral zone is totally different, and the malignancy can arise from the peripheral zone. Before concluding, I would like to give a few tips for general practitioners and consultants while treating people with benign prostatic enlargement. So if the patient is going to have renal failure, elevated creatinine values and prostatomegaly, please avoid silodosin. Put these patients on tamsulosin. Tamsulosin is a very good drug because the dose need not be adjusted in renal failure, whereas silodosin requires dose adjustment in renal failure and liver failure. If the patient is going to have prostatic enlargement and nocturia, going to washroom during nighttime often, Silodosin is a very good drug. The other drug is naftopril, which acts on alpha-1D receptors. If the prostatic enlargement happens in young people, then there is a small hitch here, small issue here. All these drugs, the alpha blockers like tamsulosin, silodosin, doxazosin, alfuzosin, all have a very common side effect that they produce retrograde ejaculation. The ejaculate which comes outside actually goes into the bladder neck instead of coming outside, so they will have a dry ejaculation. So the only drug which doesn't have the dry ejaculation is alfuzosin. So alfuzosin, the chance of having a dry ejaculation is very less, so that can be prescribed for young people with prostatic enlargement. If somebody is having erectile dysfunction and prostatomegaly also, and they want one medication which will take care of both, then tadalafil, the next generation, not like sildenafil. Tadalafil is a long-acting drug, and it has excellent effect in relaxing the bladder neck. It has an action on the alpha receptors and phosphodiesterase inhibitor. So it has a dual action. So tadalafil can be used both for erectile dysfunction and for prostatic enlargement. BPH with overactive bladder. Somebody is having frequency, urgency, and nocturia with prostatic enlargement. Or added to that, they are also having renal failure. Then they have to be managed with anticholinergics like tolterodine. So sulfasalazine, tolterodine, all these are anticholinergic drugs, and these anticholinergic drugs can be prescribed in renal failure. Whereas if somebody is having prostatic enlargement and overactive bladder, then without renal failure, they can be managed with beta-3 agonists, which have stepped into the market recently for 5 years. Mirabegron is a wonderful drug which will act very well against the fun symptoms, frequency, urgency, nocturia symptoms. If the size of the gland is more than 35 grams, then you always add a combination therapy. Put the patient on tamsulosin or silodosin along with dutasteride. This dutasteride is the one which takes about 3 to 6 months to have its complete effect, and it reduces the size of the gland to 20 to 40%. Okay, whereas the tamsulosin or silodosin is going to give only a temporary relief till the drug is going to stay in the body. Whereas dutasteride has a long-term effect. It reduces the size of the gland 20 to 30%, and doing an ultrasound after 6 months, you can many times find the size of the gland is reduced. So I would like to insist again and ask the practitioners to write post-void residual urine whenever you give for an ultrasound, and you do a serum PSA whenever you see prostatomegaly patients. Whenever you find difficult that the patients are not responding to the medication, then something is wrong. It may be a stricture urethra, or it may be a neurogenic bladder. There are other differential diagnoses too. So I have just made it very short so that it will reach you. Thank you for listening patiently. Thank you one and all.
Ganesh, even though it is, you said it is a short presentation, it was a very crisp presentation, and I also learned about many things, and it was very useful lecture indeed.
Thank you, sir.
Thanks for that. And
any questions?
Questions we can have it at the
Thank you,
end
sir.
of the session.
Thank you, sir.
And Dr. Madhushankar, please.
Thank you, sir, and thank you, Dr. Ganesh. Good evening, everyone. All right, so let me share my just a moment. I'm finding it. I'm not able to. Give me a moment, please. Okay. Hope my screen is visible now.
It's visible, Madhu.
Thank you, sir. All right. So apologies for the delay.
Sir, please put it in the full screen mode, sir.
Wait. screen. Camera back. Okay, so I hope it's clear now.
Yeah, yes, please.
Thank you, sir. Yeah, okay. So I thought I'll just go a little bit fundamental into nephrology, just to brush our memories with regard to urine analysis. Looking at urine, ordering for a urine test, and interpreting it is something which all of us do on a daily basis. We tend to come across lots of urine samples on a given day, a week, or a month, and we quite commonly see those samples having some pH values in them, protein, blood, or quite a lot of parameters. How much importance do we give to each one of them, and how do we really value the urine that is collected? Let's just brush our memories. Let's see if we all follow what exactly has to be followed. Well, kidneys are one of the most sophisticated filters ever created. Someone once said in a joking way that kidneys have the capacity to convert a good glass of a drink into nothing but urine. So when we look at a renal blood flow, it is around 1200 mLs per minute, which is roughly 25% of the cardiac output. When you compare it, when you compare the blood flow on per gram dry weight, carotid body has the highest blood flow, followed by kidneys. In that amount, the kidneys does a lot of work. It tends to filter, and then it secretes, excretes, absorbs, reabsorbs, and those nephrons do a whole lot of work after filtration. So the glomerular filtration is like 125 mLs per minute, which roughly equates to 180 liters per day, which is nothing but 30 times of a total blood volume. Of all 180 liters that is filtered, roughly around 178.5 is reabsorbed, and only 1.5 liters is excreted outside as urine. And within that quantity, we tend to eliminate whatever we have in excess, whatever we do not need, and whatever needs to be done to maintain the homeostasis of the body. This amount, the 1.5 liter, is in a normal given day when someone is normally hydrated. The quantity roughly varies. It can go down to as low as 500 ml, or it can go up to less than 50 ml per kg, depending upon the hydration of the patient. Now, blood supply to the kidneys are very unique. The renal artery divides into interlobar artery, which further divides into arcuate arteries and interlobular arteries. From them, the afferent arterioles arise, which supplies the glomeruli and then leaves the glomeruli as an efferent arteriole. And it is the efferent arteriole that supplies rest of the nephron. So the direct blood supply comes to the glomerulus, and whatever leaves the glomerulus supplies rest of the nephron. It supplies the proximal tubule, the loop of Henle, distal tubule, and including medulla. So which means renal medulla is one of the least perfused, or which receives the least perfusion in terms of blood flow, and that is more prone to any ischemic event, be it a septic shock or a hypotension due to blood loss or whatever. So this unique blood supply makes kidneys more prone to injury, because anything that affects glomerulus, the same discarded blood is carried downstream, so that is invariably going to affect the tubule and interstitium. So when the injury spreads from glomerulus to tubule and interstitium, when the injury becomes a scar into a fibrosis, then the outcome is really very bad. So this is the reason kidneys are affected widely in illnesses or diseases that has huge vascular involvement, like diabetes, hypertension, which is a disease of blood vessels, or any vasculitis for that matter, lupus, systemic lupus erythematosus, or ANCA-associated vasculitis, sepsis, or drugs which are distributed widely inside the blood vessels. Now, the renal involvement in vasculitis is peculiarly seen in those diseases which involve small and medium vessels. Those diseases which involve large vessels are not commonly associated with renal involvement. Even other inflammatory disorders which do not have a vascular involvement may not cause renal injury. Now, it is very wisely said that if we want to look at the vasculature in the body, if we want to assess, then there are only two sides. One, if you want to look at the blood vessel, then the fundus is the best place where you can get a very good idea of what is happening. Example being diabetic retinopathy, hypertensive retinopathy, we tend to get a lot of information, whether there's a bleeding or a neovascularization or constriction, we get a lot of information. The functionality is depicted, or that is shown in urine analysis. We get to have a very good idea of what is happening in the blood vessels, what is happening to the endothelium. Is there an integrity that is maintained, or the integrity that is broken, leading to proteinuria, hematuria? So all those informations can be assessed with a simple urine strip. But what is much more important is how good or how much assessment or how much emphasis we give to the collection of the urine. Classically, what we all were taught in the med school is to collect early morning sample. But there are few authors who argue that second sample is better than the first sample. The reason being the first sample is something that has stayed in the bladder for a longer time. So it is prone to lysis, particularly it lyses white blood cells. So we may have false negative results. But whether it is first or second, we always must make sure that it should be the same collection should be followed over a serial assessment. Midstream sample is very important, particularly when it comes to assessing the urine for any infection. And one should have made it clear that they should refrain from any strenuous physical activity, including intercourse, for at least 24 to 48 hours prior to urine collection. And women are better instructed to avoid urine for examination during their cycles. What is much more important is how to time for 24-hour urine collection. Most of us tend to collect between a specific timing from 6 a.m. to 6 a.m. or 8 a.m. to 8 a.m., but that is not the way it works. The specific instruction should be given to start collecting from the second sample in the morning throughout the day till the first sample of the next morning. So that is the specific way to collect a 24-hour urine collection. Anything other than this might give us a false assessment. There might be some over collection or under collection. The representation will not be exact. The urine that is collected must be analyzed within 3 hours. We can use formaldehyde or glutaraldehyde for storage, but it can be stored in 4 to 8 degrees Celsius. Most commonly, we assess with reagent strips and microscopy. Now, reagent strips has made our job very easy. Just a simple dip will give us data nearly around 10 different parameters, starting from pH, presence of protein, presence of blood, pus cells, and whatnot. I think the text is missing here. My apologies. Now, the first and the foremost parameter we look at when we collect a urine sample is the color. Normally, in a well-hydrated person, it is straw-colored, light colored. But when the color is altered, we should not forget certain important questions like drugs. For example, rifampicin, which can give an orange color. Antibiotic like imipenem, cilastatin, which can give a dark color on standing. And we should also not forget their diet history. If they had taken beetroot, which can also give a high color to the urine. pH is the next parameter. Now, strips can detect between a pH of 5 to 9, but urine or the kidney have a phenomenal capacity to make the urine more acidic or more alkaline, depending upon the blood pH, or depending upon the acid-base balance in the blood. That is reflected in the urine. Whenever body is in metabolic acidosis, the urine tends to eliminate more acid. The kidneys eliminate more acid in the urine, so the urine becomes acidic. The opposite happens during metabolic alkalosis. So pH in the urine can vary wildly, but most of the strips detect only between 5 to 9. Now, the importance of pH is noticed in stone disease.
Sorry for disturbing, sir. Sir, your slides is not getting moving, sir. First slide, sir, இருக்குங்க sir. First slide. நீங்க move பண்றீங்களாங்க sir?
Okay, all right. So, see, when the pH is acidic, it can precipitate uric acids, urates. Now, when we assess renal calculus disease, we do a 24-hour urine analysis and we look at multiple parameters, including uric acid, phosphates, oxalates, sodium, and stuff. Even though if the 24-hour uric acid excretion in the urine is within normal limits, if the pH is acidic, then the acidic urine by itself can favor uric acid precipitation, which can form as a nuclei on which calcium and other stuffs can precipitate and form a stone. So in that scenario, it is always prudent to make the urine more alkaline. On the contrary, when we overuse urine alkalizers like citralca or Kcit or anoculi, in an alkaline pH, in an alkaline urine, phosphate can precipitate, leading to more phosphate stone. So ideally, we should keep the urine pH between 6.5 to 7.5 for a renal calculus disease. And as we know, eating more non-veg foods might make the urine more acidic, and on the contrary, vegetarian foods can make the urine alkaline. This is one of the reasons where we advise people with renal calculus disease to be better hydrated and to avoid non-vegetarian food as a source of protein. Reason being, in both the conditions, when they are volume depleted or when they consume more non-veg foods, the urine may be more acidic. There's a friend of mine who had a specific complaint. Whenever he ate chicken, the night and the next day he had a burning micturition. That doesn't happen when he consumes vegetarian food. The reason is simple: a non-vegetarian food, acidic urine, the uric acid crystal precipitates. That might be the reason for irritation. Right. So this is where the most of the focus is going to be, and how to deal with proteinuria and the hematuria. Well, a population-wide screening for a protein and blood in the urine has unraveled many diseases. For example, IgA nephropathy, particularly in school children in Japan. But that is not a very wise screening method. We should always target high-risk population with urine analysis for protein and blood, particularly those with diabetes mellitus, those with hypertension, those with any vascular disease. When it comes to macrohematuria, which is nothing but a gross blood in the urine, if it is from glomeruli, the color is likely to be cola colored or a smoky color, a slightly brownish in color. And if it is of glomerular origin, we also can find more protein in the urine, some renal dysfunction. The most common causes for glomerular hematuria are post-infectious or an IgA nephropathy. Now, the differentiation between them is a little easy. It's the latent period after the onset of infection to finding blood in the urine. If it happens immediately within a day or two, which we call as synpharyngitic hematuria, that is, they get hematuria on the day or the very next day they develop pharyngitis or an upper respiratory tract infection, that is IgA nephropathy. Whereas in post-infectious, post-streptococcal, it takes around a week's time. When the urine is grossly bloody, it contains clots, then obviously it is urological cause. The site could be anywhere from the collecting system, the urethra, bladder, ureter, down till the meatus. Now, when we find a glomerular cause for gross hematuria, the follow-up is mandatory. It could be a simple, plain, straightforward case of post-infectious, but even in those cases, follow-up is mandatory, because what we find these days is in future course, on following up, most of these post-infectious glomerulonephritis do turn out into a more devastating disease called C3GN, for which the treatment is still evolving, and these conditions progress on to end-stage renal disease quite over a period of time. So even if the diagnosis is straightforward as a post-streptococcal post-infectious, it is mandatory we do complements like C3 and C4 12 weeks later and follow them regularly. a simple urine examination along with the renal function would do. Now, coming to microhematuria, it is when the blood is not visible to the naked eye, but it is found out in urine examination. When we find 3 or more WBCs, let us more than 2 RBCs, I'm sorry, in a high power field of a spun urine sediment, that is when we call as microhematuria. When that is depicted in a urine result, the next thing to look for is the presence of acanthocytes or RBC cast. This is what a typical RBC cast would look like. The cast is made up of TAM-Haswell protein, also called as uromodulin, which is secreted down the loop of Henle. As the elements RBCs or WBCs pass through the lumen, they get entangled in the web formed by TAM-Haswell protein, and they are passed out in the urine. A simple microscopic examination under usual light microscopy will give us this picture. Now, acanthocytes are even funnier things. They have this typical Mickey Mouse appearance, and camera. In this. Sorry, I guess there was some problem with the slide sharing. I hope this is...
No, Dr. Madhu, you share your entire screen.
Yeah, that my entire screen is being shared, sir. I don't understand what the problem is.
Okay.
Is it visible or not visible?
Now it's visible, sir.
Now it is visible. Okay. So yeah, these are acanthocytes. These are funny Mickey Mouse looking red cells, which again, these are nothing but a deformed red cells, which happens when red cells squeeze into the urine space through the endothelium and the glomerular basement membrane. So whenever this bleeding comes from the glomeruli, in addition to these findings like red cell cast, acanthocytes, these acanthocytes need a phase contrast microscopy. They are not usually visible with the microscope that all of us use in the lab. So they need a specialized equipment. But all of us can spin the urine and look in for a red cell cast. So in addition to these findings, glomerular source of bleeding would also have a proteinuria in a significant quantity. They might also have a new onset hypertension and renal dysfunction. Now, the evaluation for glomerular hematuria or microhematuria for that matter always involves imaging, a simple ultrasound image, which will give us quite a lot of information about the kidney size, their echogenicity, presence or absence of any cysts or mass in the kidney, downstream stones, any other problem in the ureter, bladder, urethra. We can get a fair idea with an imaging like an ultrasound, and on which we can do a CT if there is a need. A culture is always done because an urine culture is another common reason for pyuria and microhematuria. As I said, white cells can get lysed if they stay in the bladder for a longer time, in which case we will only be left out with red cells in the urine. A biopsy is mandatory when we think it is a glomerulonephritis, and in almost all the cases, biopsy gives us a clue which is not given by any investigations ever, be it an imaging or be it blood or urine. An imaging might show that the kidneys are a marginal kidney, their corticomedullary differentiation is not great. It might always be reported as a medical renal disease. But when we do a biopsy, we do find lots of new information on which we build our therapy, and there's a good recovery in most of the cases. And as I said, presence of more than acanthocytes, 5% of acanthocytes, dysmorphic RBCs, cast and proteinuria are indicative of glomerular origin. Now, glomerular origin of bleeding is associated with a significant proteinuria, which can be nephrotic range. But there are conditions when there may not be a significant proteinuria, but still it can be from the glomeruli. It happens if the excreted, the protein that leaks is of a little quantity, which is reabsorbed by the tubules. There's a very classical condition called overflow proteinuria, which I'll be explaining later. In a condition called myeloma, where there is excess secretion of monoclonal proteins, they are filtered by the glomeruli and reabsorbed by the tubules and metabolized. When the capacity of the tubule to reabsorb and metabolize this monoclonal protein is overwhelmed, that is when these proteins start appearing in the urine. Till the time we may not find a significant proteinuria. So an absence of a significant proteinuria does not mean that the bleeding is not from the glomeruli. And again, we should also be aware of when not to put the guns. When despite having made a diagnosis of glomerular origin hematuria, if the patient has a normal renal function, pressures are normal, and if the proteinuria is not significant, we may as well wait, follow up, and then decide on a biopsy at a later time. Because in most of these cases, if the study shows that an early biopsy has led to a diagnosis of a thin basement membrane disease, which is very, very benign, an early case of IgA nephropathy, which just needs a follow-up. So those cases, we don't have to do a biopsy every time. We just need a close follow-up of those cases. And not to forget the non-glomerular causes beyond the kidney, urological causes like a stone or a mass or any other structures. When the age is more and when the evaluation is not suggestive of glomerular, we must never forget a cystoscopy may be mandatory in addition to ultrasound or CT. Now coming to proteinuria, we all know that normally we pass around 150 milligrams a day, of which 30 milligrams would be albumin. Anything more than that should be seriously looked into. Now, glomerular origin proteinuria is when the proteinuria is significant, it is of nephrotic range associated with edema and other features of nephrotic syndrome, then there is no doubt that it is glomerular. Overflow proteinuria, which I just mentioned, in multiple myeloma and other plasma cell dyscrasias, when the capacity of the proximal tubule to reabsorb the filtered protein is overwhelmed, then they spill into the urine. Tubules also secrete protein, which is mostly microglobulin alpha, alpha 1, beta 2. But the quantity on a given day is around 1 to 2 grams. Anything more than 3.5 grams is invariably of glomerular origin. Orthostatic proteinuria is a condition where the protein leaks into the urine only when the person is up and moving. When he's sleeping overnight and wakes up in the morning and does a urine analysis of the first morning sample, there is no proteinuria. But when the person starts moving around and when the urine analysis is done, when he's up and moving, then we find protein in that sample. That is called as orthostatic proteinuria. There is the sieving capacity or the filtering capacity of the endothelium and the podocyte is overwhelmed in these cases. In most of the cases, this is benign, does not lead to a big long-term renal dysfunction. Now, when the proteinuria is more than 1 grams, despite using maximum RAS inhibitors, with the microhematuria and renal dysfunction, then there is no turning back. He needs a biopsy. This will be a quick idea about how to measure. Most of the time we use a reagent strip, and that is based on the color change. Reagent strip is qualitative, or at the most it is semi-quantitative. Now, a reagent strip for a protein may be falsely negative when the protein that is leaking in the urine is very less than the capacity of the strip to detect. That is when it is less than 0.3 grams per liter. And we should remember that the strip detects only albumin. It does not detect a tubular protein, or it does not detect a monoclonal protein which overflows. So in those conditions, when the proteinuria is of tubular origin, or when there is a plasma cell dyscrasia, the strips might still be negative, but they are falsely negative. Again, the strips are also sensitive to pH and hydration. When it is more alkaline and dehydrated, it can be false. So when we order for a urine routine, and when we find that the dipstick protein is negative, there are a few conditions where it can be falsely negative. And in those cases, we may have to use an albumin creatinine ratio, which is slightly more sensitive, which has a better semi-quantitative analysis, or even we have to go for a 24-hour urine collection. Short of 24-hour urine collection, we have two techniques. One is protein creatinine ratio, and other is albumin creatinine ratio. Here we calculate the albumin and the creatinine and then put a ratio to it. Most of the time we find urine microalbumin without creatinine, which is not right, because the albumin elimination or the secretion in the urine does not happen throughout the day in a uniform way, which means for some time you can have a massive elimination, and for quite a long time there may be no protein that is passing in the urine. Similarly, the protein that is passed in the urine is also, the quantification also depends upon the volume of the urine, which is again determined by the creatinine. So to eliminate the bias of the volume that has its effect on the protein that is eliminated in the urine, we use protein to creatinine ratio. So whenever we order for a microalbumin or a protein, it has always it has to be accompanied with the urine creatinine, and what we have to interpret is the urine protein creatinine ratio or the albumin creatinine ratio, never the urine protein or urine microalbumin. An isolated assessment of urine microalbumin is not going to give us any information. Whether it is ACR or PCR, generally the world bodies recommend albumin creatinine ratio, because PCR can be poorly correlated at high levels, particularly in lupus nephritis. Again, as I said, even albumin creatinine ratio will be negative in tubular or monoclonal gammopathies, because it detects only albumin. A tubular protein is more of a microglobulin, and monoclonal gammopathies secrete different proteins altogether. Again, when we go for 24-hour collection, we must always have a 24-hour urine creatinine along with it, because that will give us an idea about appropriateness of the urine collection. We tend to either over collect or under collect, which we can always assess by looking at the creatinine in the urine. Women roughly secrete around 10 to 15 milligrams of creatinine per kg in a day, whereas men secrete more than that, 15 to 25 milligrams. So any elevated protein in the urine should always be confirmed with a 24-hour collection. And what is more important is we must use a single measure for follow-up. When we use albumin creatinine ratio, that should be used throughout the follow-up. We cannot mix match, because the sensitivity varies wildly. Again, CAST are nothing but what is made up of Tham-Hasfall protein. And we should also recognize, we should remember that hyaline or a hyaline granular CAST or an occasional uric acid or calcium crystals in the urine are a normal finding. Finally, coming to a couple of closing slides. The importance of urine analysis. When we look at systemic lupus erythematosus, when they have reclassified this, American rheumatology have given a point system. What it shows is that the maximum points are allocated to the renal involvement. When we have a biopsy suggesting class 3, class 4 lupus, they give a whole 10 points, which is good enough to make a diagnosis. So even if serum C3, C4 is normal, ANA, dsDNA, everything is negative, if you have a renal involvement and if you biopsy and show there is class 3 and class 4, that is a diagnosis of systemic lupus erythematosus and lupus nephritis. And another big chunk of points are given to proteinuria. Similarly, we might be following diabetics serially, but all of a sudden we might find that there is a sudden increase in proteinuria or a sudden onset of microhematuria in their urine, which will also alert us to the presence of or to the development of a non-diabetic kidney disease in diabetics, which could be a superimposed IgA nephropathy or a monoclonal gammopathy or even a minimal change disease. Well, so the take home would be whether to collect the first morning sample or a second morning sample. It again depends. It again depends on the convenience of the patient as well. If someone can come and give the first morning sample or they can collect at home, that's fine. Or even a second sample is also good. But on a serial follow-up, we should follow the same sample. The collection should be meticulous, whether it is ACR or PCR. ACR is preferred over PCR except in children, and never make a mistake of assessing the urine for microalbumin alone. Always assess it along with the creatinine ratio. And 24-hour collection comes with second morning sample throughout the day till the first morning sample, not like 6 to 6 or 8 to 8. And we should have a fair idea of what we are dealing with, whether it is glomerular or non-glomerular renal or a urological cause, and then order for further investigations and diagnose accordingly. What might look as a simple investigation, just a simple dipstick, does give a big clue about the entire vasculature in the body, and that will actually lead us to a different diagnosis altogether. So I think with this, I would like to complete. Thank you, and thanks everyone for listening to me.
Thank you, Madhu.
Thank you, sir.
It was, a very basic subject, but most of us probably were not knowing many of the things. And it was very useful.
Thank you, sir.
Any questions from the participants? Any questions or any suggestions for both the consultants?
Hi, sir. Good evening. I am Videsh.
Yeah, good evening. Please.
Sir, actually, my question is to Dr. Ganesh Prasad, sir. May I ask him now?
Yes, Videsh, you are audible. You can go ahead.
Actually, my question is related to sensory receptors, sir.
Okay.
Like we know that due to like few neurological disorders and vitamin deficiency, we may lose our sensory functions, right?
Yes, absolutely.
Will we be able to regenerate those lost sensory functions, sir?
Okay. So I'll give you an example. Suppose there are 100 neurons, and it's not a all or none law.
Okay,
There may
sir.
be a lose. You may be losing around 70 to 80 neurons. 20 neurons may be still working there. So the bethanacol which we give for these neurogenic bladders sometimes may help these 20-30 neurons to pump the urine out. The basic concept is that. So if you take it as all or none law, then it won't be applicable here. Still, the neurological function may recover in certain people who have neurological loss because it's not a all or none law. Hope you understand.
Okay, sir. Thank you, sir.
If there are no further questions, I thank Dr. Ganesh Prasad and Dr. Madhushankar for taking their time out and participating in this webinar, giving their wonderful lectures. Thank you, both of them. And on behalf of Ramakrishna Hospital, I thank all the consultants, doctors who have participated in this webinar. Thank you, everyone. Thank you.
Thank you, Dean sir, for the opportunity. And I thank the management for giving us an opportunity to hear our views online. Thank you.
Thank you and good evening, everyone. Thank you, sir.
Ganesh?
Sir?
No, this Murali.
Sir, thank you, sir.
Yeah, you can close this.
Yes, sir. Yes, sir. We can close it, sir. Thank you, sir. Have a nice evening, sir.
Sir, thank you, sir.